Good afternoon and welcome to today's program, titled Involving People Who Use Drugs to Design and Deliver Health Promotion Programs for People Who Use Drugs. I'm Gary Enos, editor with the Institute for the Advancement of Behavioral Healthcare. Today's program is sponsored by RTI International. Thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we have a few details we'd like to go over. To submit a question or a technical issue, please use the Q&A area below the slides at any time. You do not have to wait until the end of the program to submit a question. To download a copy of the presentation, please click the link in the Resources tab to the right of your slides. I have a special note about CE credit. To get your CE, you must watch the program all the way through the Q&A section at the end of the presentation. At the end, do not leave the web page. The site will automatically redirect you to a survey. This must be completed in order to generate your CE certificate. For those who are watching in a group, please download the group submission guide in the Resources tab and follow the instructions provided. Please note that CE credit is not available for the archived webinar. It is only available for the live event on September 6, 2018. Finally, for those of you who tweet, please tweet along with us using the hashtag IABHCLiveWebinar. At this time, it is my pleasure to introduce our speaker for today, John E. Zabel. Dr. Zabel is a senior public health scientist in the Behavioral and Urban Health Program at RTI International, where he conducts behavioral epidemiological research on risk factors and health outcomes associated with the opioid epidemic and injection drug use. Before coming to RTI, Dr. Zabel worked as a Centers for Disease Control and Prevention health scientist in the divisions of viral hepatitis and unintentional injury prevention. Thank you, John, for taking the time to speak with us today, and with that, the audience is yours.
Okay, thanks, Gary. Hi, everybody. First and foremost, really, let me say thanks for taking the time out of your busy day to sit for this webinar. In particular, I want to extend a special thanks to Dr. Craig Humbaugh, the Commissioner of Health for the Lexington-Fayette County in the great state of Kentucky. A month ago, during a statewide hepatitis conference, Dr. Humbaugh approached me with questions about how best to include peers in the delivery of harm reduction programs, specifically syringe services programs. His questioning and the discussion we had made me realize that the methods for incorporating peers in harm reduction service delivery is far from straightforward, nor is it simple to implement. And given the increase in the number of SSPs around the country, particularly in the South and the Midwest, I thought the issue was timely and important to address as a webinar. So I want to extend an additional thanks to the organizers of the RX Summit for providing me a platform to present this important material. Over the last several years, SAMHSA and other federal agencies have come out in support of using peers to help people with substance use and mental health disorders live with and recover from their illnesses. Given this increased interest by the federal government, in this webinar, I will make the case that people who use drugs should be considered appropriate and effective peers for helping deliver services to people who, like themselves, actively use or know what it's like to use illegal drugs. To some, however, especially my friends in law enforcement and those working in drug treatment, this claim may seem like a quixotic or naive proposition. But one only has to examine the history of the AIDS epidemic, and particularly the birth of harm reduction movement in the early 1990s, to see that the claim for using persons who use drugs as peers has historical precedent and should be taken very seriously. Indeed, the principles of harm reduction developed by the Harm Reduction Working Group in 1993 demonstrate this sentiment by insisting that, quote, drug users and those with a history of drug use should have a real voice in the creation of programs and policies designed to serve them. These principles further affirm that harm reduction services should, quote, seek to empower users to share information and support each other in strategies that meet their actual conditions of drug use. What I'm suggesting here is that the claim that persons who use drugs should be involved in the design and delivery of health interventions that serve drug users is not only a founding principle of harm reduction, but it's grounded in the development of injection-related HIV prevention itself. It's important to note that harm reduction activism at this time evolved as a direct response to the AIDS crisis. And this was at a time when more than 50% of persons who inject drugs were infected with HIV, and where most infected persons died. Specifically, needle exchange was designed by people who use drugs. Once it was discovered that HIV was a blood-borne pathogen, and one of the risk factors was parental exposure from injection drug use, it was designed by people who use drugs prior to any evidence demonstrating efficacy. Members of ACT UP, which was the advocacy group, the AIDS Coalition to Unleash Power, actually organized public needle swaps to get clean needles into the hands of people who inject drugs. And in fact, activists challenged the police to arrest them, and in doing so, challenged paraphernalia laws themselves. Harm reduction, therefore, has its early roots in these illegal needle exchanges. But it's important to note that during this time, hypodermic needles used for non-medical use were considered drug paraphernalia, and possession was a criminal offense in nearly all states in the Union. In some jurisdictions, punishment was a 12-month prison sentence, and in some jurisdictions it still is. So possessing and distributing needles was against the law in most of the United States during the first decade and a half of the AIDS epidemic. And the ban on using federal funds for needle exchange only ended several years ago. In response, AIDS activists demanded that paraphernalia laws be changed given the new evidence of vectors of transmission as a way to get sterile syringes into the hands of persons who injected drugs in order to reduce syringe sharing associated with needle scarcity. But these initial efforts were unsuccessful. The history of AIDS activism, in just this one example, can be thus seen, like other civil rights issues, as a result of an antagonism between civil society and the state, especially when the state refuses to act to protect its most vulnerable citizens. In the case of needle exchange, the antagonism is between law enforcement and public health over the best way to protect civil society from the harms wrought by illegal drugs. So once HIV was identified as a blood-borne virus transmitted by sharing needles, needle exchange was immediately caught up at the intersection of two contradictory policy logics, one enforced by law enforcement and the other endorsed by public health. And while law enforcement and public health are both state institutions, they each have institutional logics for how they view illegal drug use and the cause of harm. For example, on the left side of the figure, I identify the logic of law enforcement as concerns needle exchange and needles generally. Law enforcement is charged with fighting illegal drug use through drug control strategies of interdiction, incarceration, and rehabilitation. Law enforcement regulates the possession and sale of syringes by legally classifying non-medical use as paraphernalia to ensure that needles are not readily available. In other words, to produce needle scarcity. Needle scarcity here is thus seen as a positive strategy to protect civil society from the dangers of drug injecting and addiction. The logic represents a punitive approach because it's based on the moralism surrounding illegal drugs and not necessarily the evidence associated with the practices. Public health, on the other hand, is charged with protecting the health of society by rendering illegal drug use epidemiologically harmless. Needle scarcity was proven to cause needle sharing and disease transmission. Not enough syringes in the illicit market, people started sharing syringes as a vector for transmission. Restrictive needle policies thus increased bloodborne infections. So public health eventually came around to support the liberalization of needles as a strategy to protect society from infectious disease and death. This logic was a pragmatic approach based on the scientific evidence to protect the public health. This cultural struggle is the institutional terrain where the punitive logic of law enforcement is antagonistic to the epidemiologic of public health. As an aside, I would also suggest that this same tension is driving the current debate on safer consumption spaces. And like needle exchange, this tension is the driving force motivating both activism around the program and research to demonstrate its efficacy. Now, as the AIDS epidemic was generating high mortality rates similar to the current rate of opioid overdose deaths, concerned citizens, most of whom had friends and family members die from AIDS, were wrestling with just how to challenge state paraphernalia laws, as these laws prevented them from distributing sterile syringes as a means to prevent sharing and new infections. Most of these folks had families and good-paying jobs at the time. They were not radical in any historical sense of the term. They did not want to break the law and get arrested, and they had hopes in the legislative process and the American system of government. But when the legislative process proved impotent and unable to respond to the burgeoning AIDS crisis, specifically around injection drug use, which was a crisis of unprecedented proportion at the time, these same citizens became incensed by what they saw as the state causing deaths, so to speak, because they were unnecessarily and preventable. Many harm reductionists were influenced by the spirit of American civil rights movement and decided to follow King's path of nonviolent direct action, and they started setting up on-the-spot needle exchanges in a handful of the most affected and high-burden cities. For example, top left going clockwise, this is John Parker in the AIDS Brigade in 1989, cover story in the New York Times, where he was doing an illegal needle swap and actually teaching people how to rinse their syringes with bleach and water. Further to the right is Dave Purchase of the North American Syringe Exchange Network. This was in 1988, 1989. Dave actually risked arrest and started distributing needles on the streets of Tacoma, Washington, by himself, and then started to form a group. Further down is Dan Bigg in the Chicago Recovery Alliance, who started doing needle exchange on the streets of Chicago in the late 90s, early 2000s. And then finally is the Truck for Clean Needles Now, an outfit out of L.A., and they were doing street exchange in the MacArthur Park neighborhood, and this is around 1995. Sorry, that slide actually just popped up. I apologize about that. I didn't hit it, so I want to take a second. John Parker on the upper left, Dave Purchase on the right going clockwise, Dan Bigg in the Chicago Recovery Alliance, and then Clean Needles Now in L.A. All of these programs were extra legal, so to speak. People were taking risks based on the evidence around vectors of transmission before there was evidence for needle exchange, and just doing it for the reasons that I said before. But it's important to note it wasn't just needle exchange. It was naloxone. And Dan Bigg was a giant in this area and supported and implemented the mass distribution of Narcan around the United States. He started in the late 1990s, very prescient in foreseeing the current opioid overdose crisis, and he never let up, even until the day he died, on the importance of getting naloxone into the hands of who he perceived as the true first responders, which are people who actively use drugs, since they're the ones first on the scene and thus in the best position to administer naloxone during an overdose. Sorry, they're just jumping ahead. So what I'm trying to demonstrate by presenting this history is that the two most successful evidence-based programs we have currently to prevent infectious disease and opioid overdose, that is, lay naloxone and needle exchange, were developed and implemented by former and active drug users well before there was evidence available to prove their efficacy and without the support of state and federal government. But the recent opioid epidemic changed all that. Presently, lay naloxone and syringe services are supported by both the federal government and a growing number of states. There are many reasons for this sea change as compared to the AIDS epidemic, and all of them are well beyond the scope of this presentation. But what I want to offer with this slide is an explanation for why people who use drugs are no longer seen as central to the delivery of harm reduction services as they once were. What happened? I suggest to you that the drift away from harm reduction's first principles can be seen as what happens generally when community-based organizations are endorsed, supported, and ultimately funded by the federal government and state health departments. In other words, when harm reduction evolves into an industry. One of these ways, which is the third bullet on this slide, is the way that people who use drugs have been reduced to program participants, clients, or patients, not people with the skills to help create, design, and deliver services. This is partly because medical professionals and healthcare workers often have a hard time seeing drug users beyond the caricature of the chaotic and dysfunctional junkie, mainly due to the stigma that pervades the medical system, and even some harm reduction organizations themselves, I may add. This stigma, in addition to the manifest challenges associated with employing PWUD, are the main reasons why organizations often embrace former users or people in abstinence-based recovery as peers. An example of this outcome has been the strengthening of extreme stereotypical views among service providers in how they perceive the character of people who use drugs. And I put these as extreme examples. On the left is what I'm calling a traditional example. And here's a quote exemplifying. Drug addicts are all scammers and should not be trusted. They are unreliable and prone to lying and thieving. They will do anything to get their fix. This stereotypical and pejorative view is commonly held by service providers. I've heard it multiple times over the years, but it's really articulated for good reason. The alternative version is represented by this quote. Drug users are oppressed and vulnerable persons whose insights are automatically worthy of attention and credibility, just because they're drug users as such. This view, I would suggest, is equally stereotypical and just as misleading. In the middle is what I would say is a rational view, and this is the view that is more supported by the evidence and by people who work in the field who ultimately come around to this position. And this position is that people who use drugs as a group exhibit the same diversity of moral and behavioral characteristics as any other human population. Social workers, for example. There are some good and some bad. There are some mean and some pleasant. Some are selfish, some are altruistic, some are clever and some are less so. And some we'd want to hire and others that we never would. These attitudes, however, do not exist solely in just a handful of individuals. In the same way that racism, sexism, and homophobia are not limited to individuals, but embedded in the logic of institutions, the negative stereotypes of addicts and addiction are similarly embedded, but within the fabric of social services, especially services that provide services to people who use drugs. This pejorative logic produces an effect akin to institutional racism, which is why Peter McDermott has referred to this as institutional addictophobia. Unfortunately, though, changing people's views on injection-related risk is a Herculean task because those most at risk for HIV infection or HCV infection or overdose are people whose behaviors are already seen as immoral and irresponsible. What I mean to suggest here is that since drug injecting and gay sex were socially and politically demonized well before the onset of HIV and hepatitis C, people's ability to recognize the complexity of drug use is always already poisoned by the moral judgments of society. This is where the role of professional training and sensitivity training would fit in order to counter both the stereotypes and reestablish that the client/patient is a human being with a chronic relapsing health condition, similar to those suffering from diabetes, obesity, depression, or other chronic health disorders. Having a complex and realistic understanding of the diversity of persons that fall under the categorization of drug user is a productive first step towards seeing people who use drugs as potential peers. Let me illustrate an expanded definition of peer offered by the Harm Reduction Coalition to demonstrate my logic. In this document, they say persons serving as peers in harm reduction services rather than being legitimized through academic credentials, draw their legitimacy from experiential knowledge and experiential expertise. Experiential knowledge is information acquired about harm reduction through the process of one's own use or being with others that use. Experiential expertise entails the ability to translate this knowledge into skills that can be passed on to others. Many people have acquired experiential knowledge about harm reduction, but those who have the added dimension of experiential expertise are ideal candidates for the role of peer. Please note, though, that none of these skills or attributes have anything to do with what stage someone is in with their drug use. People with experience and knowledge of drug use can be ex-users. They can be people in abstinence-based recovery, people on opiate agonist therapy, otherwise known as MAT. But they can also be people who manage their drug use, or who use drugs socially, or those whose drug use is problematic or even chaotic. Either way you slice it, when confronted with the question of who makes a good peer for harm reduction services, it's extremely difficult not to see people who have experience using drugs, current or previous, as the most appropriate and relevant peer. It's in the spirit of developing a more complex understanding of illegal drug use, it's important to recognize that drug use exists on a continuum, not a static position, that goes from back and forth, from non-problem use to managed use to abuse to chaotic use. This figure demonstrates the myriad pathways that drug use and abuse can travel. For instance, someone can start off in an abstinence, right, not using, and they experiment with drugs, and then they stop and there's no further use. Some people experiment and they continue to use drugs recreationally, but not having any problems with their use. Some people will use in a non-problematic way, but that can develop into substance abuse, meaning you're using for a particular effect beyond what the medication is prescribed for, or you're using an illicit drug that has no quote-unquote medical use. And that substance abuse can develop into a substance dependency. And dependency is usually psychological and or physical. That substance dependency, let's say physical dependency, can be managed. An example of that would be methadone or buprenorphine or even heroin that's used as a heroin prescription program in some European countries. This dependence is a physiological dependence that is just quelled with the consumption of a substance. So you're physically dependent on methadone or buprenorphine, but that dependence is managed because you have access to your drug and you take it regularly. Substance dependence is different from addiction, and this is key to highlight. Dependency is the physiological use, continued, and with an opioid, you will go into withdrawal if cessation occurs. That's different than addiction. Addiction is dependency, but with a compulsion that continues even in the face of negative consequences. So even as your life, quote unquote, falls apart, you start losing things, you still have the compulsion to use, even in the face of that. That addiction can go back and forth to manage use. I've interviewed and written about many people who have addictions, but then end up managing their use, and they struggle doing that. Some people go from an addiction to going on methadone, and now they have a managed use as well. So it fluctuates even amongst an individual along this continuum. The most misunderstood part of addiction, I would argue, is that difference between drug addiction and drug dependency, like I just mentioned. The goal of MAT or opiate agonist therapy is to move people from, let's say if we use opioids as an example, opioid addiction to opioid dependency. Right? They're using a drug, they're using heroin on the street, they're physically addicted. When they don't get that drug, they go into withdrawal. They'll do things to get money, to get their fix, to quell their sickness, even in the face of negative consequences. That's different than someone that wakes up in the morning, is physically dependent on methadone, goes to the clinic, gets their dose, and goes about their day. The goal of MAT is to move people from addiction to managed use. And this is really misunderstood. And I think until we don't really understand this in a more deeper, nuanced way, it's really difficult to advocate for opiate agonist therapy on a large scale. But social services, it's important to note, are known to attract the most chaotic and problematic drug users, particularly needle exchanges. So the image most service workers have of people who use drugs are people enslaved to their compulsion, who will do anything to get a fix. Ergo, they're perceived as totally unable or unwilling to do anything else. This reductive way of understanding substance use disorders leads to the stereotyping of drug users as chaotic, dysfunctional, and not caring about anything but the next high. Now, of course, there are people who use drugs that fit this description. This is why stereotypes seem reasonable. And it's also the reason why stereotypes are so powerful. But this caricature represents only a very small percentage of people who use drugs. In fact, the National Institute of Drug Abuse estimates that 23% of individuals who use heroin go on to develop an opioid use disorder. This translates to nearly 3/4 of people who actively use heroin not developing an addiction to the drug. Let me go further and say that this statistic follows Pareto's principle, which is a theory of economics, otherwise known as the 80-20 rule, or the law of the vital few. The Pareto principle states that for many events, roughly 80% of the effects come from 20% of the causes. So, for example, 80% of sales come from 20% of clients, or 80% of the wealth in society is held by 20% of the population. Or for our purposes, 80% of all the heroin-addicted related health outcomes come from only 20% of the population of heroin users. This 20% I'm suggesting represent 80% of the people who utilize SSPs. My point is that the stereotypical image of the drug user that is hegemonic in most medical and healthcare systems is not an accurate representation of the wide diversity of people in the United States who use drugs illicitly. Sorry, it's changing a little slowly. There we go. So, given the formative role people who use drugs have played in the development of two of our most effective harm reduction programs, and taken into account the fact that drug use exists on a continuum, let's now turn our discussion back to peers, and specifically the way people who use drugs can serve as peers in harm reduction programs. I want to start with volunteers, and then we'll talk about employment as the presentation moves forward. So all organizations that have PWUD as volunteers should have a certain number of things. And these are outlined in different resources that I'm going to talk about at the end of the presentation. And all of these can really require their own webinar. And so this is just a general understanding, hopefully to start a discussion around these issues. But what is clear is that there needs to be a clear job description. What is the roles and responsibility of volunteers? Right? Everything needs to be outlined. No ambiguity. This includes a minimum time frame of how much that person's going to work or volunteer. A 6-month position at 10 hours a week, per se. There needs to be a work plan, right, that outlines the person's day-to-day activities. There also needs to be discussions about drug use at work. If you're going to have people who use drugs as volunteers, there also needs to be cultural competency for staff who don't use drugs, right? Why are we having people who actively use drugs as volunteers? What's the benefits? What's some of the challenges? Staff needs to be aware of this and have discussions. There needs to be really good management as well, more management. And I would suggest coaching, per se, rather than supervision. This involves mentorship as well. A lot of volunteers don't get mentors. They're just given tasks to do around, but they're not brought under people's wings and shown how to do stuff and given training and development opportunities. Another important aspect is psychological and professional support. And I would say not just for people who use drugs as volunteers or employees, but also staff in harm reduction services more generally, or staff that works with people who use drugs more generally. Those of you working in this field know there's a lot of burnout associated working with the field. especially the way the illicit drug market is poisoned right now. We're seeing a lot of morbidity, a lot of mortality. All this death is really having an effect on people that work on the front lines. Psychological and professional support is needed for these organizations. One example is I worked at a program one time. I got my start in working in abstinence-based drug treatment, and we had a psychologist that would have a meeting once a week, and we would all sit and we would talk about work-related stuff that affected us, stuff that we went home with at night, stuff that we dreamed about, nightmares, so to speak. It was really helpful in preventing burnout, or at least delaying it in our field. There also needs to be a way of dealing with costs. Volunteers incur costs while they're on the street, while they're doing stuff, while they're working. And there needs to be a way to get them reimbursed. One of the most important is there needs to be a safe way out for volunteers. If they don't want to do it, they don't like it, they can't do it anymore, they need a way to say, I can't do this anymore, or I don't want to do this anymore. That's a hard thing to do, especially if you're trying to show that you can and do this work. And lastly, I would suggest there needs to be a path to employment for volunteers, or otherwise people just volunteer and volunteer and volunteer. But we can go a step further and actually employ people who use drugs in our programs. So why would we do something like this? Well, there are myriad reasons. Let me outline a few. People who use drugs have insights and expertise that help inform the planning, delivery, and review of harm reduction services. Working in partnership with drug users helps services reach and connect with the population more effectively. People know where to go. They know what to say. They already have the cred with their peers on the street. Having people who use drugs on staff also helps the program better understand and meet the population's needs. Employing people who use drugs sends a clear message as well that this population is valued, and they're valued as partners and welcome at all levels of service delivery. From a more kind of juridical standpoint, people who use drugs have a right to be employed, right? A marijuana smoker who's smoking in a state where it's still illegal but doesn't do so at work, it doesn't impede their work-related abilities, they have a right to be employed. No one's asking them. But there's rules that if you violate that use at work or you fail a urine test, then you suffer the consequences. And even a step further, I would say that policies that routinely exclude persons who use drugs from the workplace are discriminatory. A good understanding of this is addiction, seen as a disability in disability law, that you can't discriminate against somebody based on the fact that they have an opioid use disorder or that they're on any medications for that disorder. Sorry, everyone, just waiting for the slide to pop up. Well, the figure that you are going to see offers a really useful way to demonstrate the level of involvement for including people who use drugs and the levels of power that accompany that involvement. And I'll reach out to the technical team here just to explain that the slide is not changing. Doesn't matter, I can go anyways with it. So this figure here is actually it's a pyramid, and it starts the bottom of the pyramid to the top of the pyramid, lists different levels of involvement, and the higher you get up the pyramid, the more power you have. So the lower part of the pyramid is having people contribute, people who use drugs contribute to the work environment, hanging around, talking with people, etc. But then the next level is actually speakers, having people who use drugs speak at events, city council meeting, right? Sharing their experience, sharing their needs and challenges and barriers, right? But then they also can be used as experts or even decision makers. There's several examples of this. One low threshold example for a needle exchange program to include people who use drugs in decision making is to set up a consumer advisory board made up of program participants. I had the experience of governing one of these, or a needle exchange program that I worked in. And what it was an advisory board that was populated by people who use drugs and utilize the program. And these folks met once a month, but you could meet kind of bi-monthly, and having discussions about the program. What are some positive stuffs about the program? What are some negative stuff? What are some things? Why aren't we reaching certain people? So it's an advisory board that can give advice to the decision makers of the needle exchange. We also, in that organization, had a person who used drugs sit on all our hiring committees and had voting power. So there was a program participant that sat on the board and could actually vote on who to hire, on who they were going to engage with. An even more inclusive way would to put a participant on the board of directors, or to have a person who used drugs, a spot for that person on the board to help make decisions. That's one really simple thing that can be set up pretty easily. So I just want to name a bunch of other examples, and if the slide was up, I have a big list, and people will have access to this slide deck once it's over, and you can look at the list yourself. But I really just want to describe some of them here. So we talked about delivering needle and syringe programs, but also safer injection. An example from Vancouver is they used active drug injectors to go into the community and to show people how to safely inject. And they did this because they were seeing a rise of abscesses in the community. And there was a lot of new injectors that didn't know how to inject. They called themselves hit doctors. But they also can be used to follow up on persons who use drugs who drop out of services. The other aspect is they can promote harm reduction with stimulant users. Very hard population to penetrate and to get involved in services. And the one that I have done mostly is a partnership approach where I work with people who use drugs as partners for research, what we can call peer-driven research, but what in the anthropology community is called participatory research. And this is a partnership approach to research that equitably involves community members, organizational representatives, and researchers in all aspects of the research. And in fact, the early days of needle exchange and the evaluative research of those programs typically involve people from the community as research partners. Two examples of this is the recent debates around safe consumption spaces and fentanyl test strip technology. And we should be on slide 22 here that's showing both of these practices. What's interesting here is that safe consumption spaces, similarly to needle exchange, developed as a result of people who use drugs trying to find out ways to keep people safe who were injecting in public, who had no place to go, no homes, that were injecting in alleyways and on the streets. And people were dying en masse. In the United States, this has developed over the last several years, specifically related around the poisoning of our illicit drug market. For those who have been following my work and the work of Dan Ciccarone and his team, have come to realize that what we really have here is a poisoning epidemic. The heroin supply in the United States is poisoned. And not just poisoned with fentanyl, but poisoned with a whole array of illicitly manufactured substances. In other words, even for long-term users, it's very difficult to stay safe and use in a safer way or not to die, because even the littlest bits can push through someone's tolerance. So safe injection, safe consumption spaces are seen as an answer to that. And the answer is coming from drug users who are typically tired and have lots of trauma around seeing their friends and family members and colleagues die, even people that were taking care to protect themselves. Fentanyl test strip technology is a similar effort. Myself and my colleagues at RTI have a publication coming out in the next few weeks on behavioral outcomes associated with these test strips. We're showing that there's actually safer outcomes associated with their use. But the important point here, back to our discussion, is we didn't invent this practice. This practice has just been started by people who use drugs and harm reduction services as an all-hands-on-deck approach to the opioid epidemic, starting with people who use drugs, uptake by people who use drugs, support by harm reduction programs, and then ultimately researchers testing their efficacy and developing evidence-based approaches. So, putting that aside, let's talk about some structural barriers for recruiting people who use drugs as volunteers or employees. And these are some problems that we need to address if we're going to take it seriously. People who use drugs may have gaps in employment timelines on their resumes. People's experiences and expertise can be difficult to describe on resumes and communicate during job interviews. They may not have any experience doing formal job interviews. People who are dependent on street opioids may need to work in only 3 to 4 hour intervals. If they're dependent on heroin with a half-life of 3 to 4 hours, they will need to medicate themselves. If they're on methadone or buprenorphine, they might need to show up at a clinic in the morning. If there are long lines at that clinic, they might be late for work. People who use drugs may also have criminal records. They may navigate between managed use, problematic use, chaotic use. And they also may be hesitant to out themselves in public as a program's active drug user. Go to slide 24, please. The challenges associated with employing people who use drugs continue. Right? We got to take into a fact that people have drug addictions and drug dependence and managing that for employment. They may have close relationships with program participants. This is one of the benefits of having them as volunteers and employing them. But the line can be blurry between social relationships and programmatic and health delivery relationships. There's also health conditions that can impact people's work. I'm thinking about viral hepatitis and the fatigue that comes along with acute infections. People often report having lots of fatigue, and this can impact work as well. Criminal records. The program can have criminal exposure at some points if anything happens or if people are blamed for anything. There might be state laws that might get in the way. There might be compulsory urine screens that people have to take that they cannot pass to be either a volunteer. Drug use during work hours is something to take into account in having discussions. They might be incarcerated at different levels of time. We know that people who are arrested for minor offenses often can spend 2 or 3 days in jail and then released and not even charged. And this is hard to keep employment with that. This has been one of the arguments made against punitive drug laws, that people are being arrested and held for a certain number of days and they're not able to hold on to jobs because of this. And also the public backlash about hiring people who actively use drugs as well. Next slide to 25, please. So given these conditions, what are some strategies? Well, I think the primary one that I want to communicate here is the development of a universal code of conduct. And this is probably the most important, right? And this is that, alcohol and other drug policies should be underpinned by the principle of fitness to work, where the issue is about job performance rather than drug use itself. And what I mean by this is that people who use drugs who are employed full or part-time should be subject to the same terms and conditions of employment as with any other paid worker in the organization, given all the challenges, barriers I said, however. And so I'm thinking of alcohol use or cannabis use. There could be, in that universal code of conduct could be developed together in concert with program participants who will talk about the challenges and barriers of that. And again, I said being dependent and needing medication every 3 or 4 hours. That might come into conflict with that. But the other things are many. Health checks and immunizations are key for all staff, right? Relapse prevention. We talk about hiring former users or people in drug treatment as volunteers or employees rather than people who actively use drugs. One of the problems here is that working in an environment where people are visibly intoxicated or where drug use is discussed can be big triggers for people newly in recovery a year or two in. And so I would even suggest that it's more dangerous in terms of relapse for people that are former users working in a harm reduction program like needle exchange than active users who have a whole bunch of challenges and barriers, but relapse, so to speak, is not one of them. 26. And I only have a couple minutes left, so I just want to talk about some benefits to services and benefits to employees. Some benefits to the service. It reinforces the service's commitment to people who use drugs, draws on a rich stock of consumer knowledge, right? Strengthens the targeting of interventions, involves programmatic decision-making, collectively decided decisions, ensures services are consumer-friendly. It improves the cultural competency for non-drug using employees, increases the program's street cred to the rest of the community. And most importantly, it turns a mutual antagonism between service users and service providers into a therapeutic alliance, reducing the structural inequality between service agencies and the people they serve. Now, the benefits to people who use drugs. Please go to 27. They acquire new skills. They can develop a recent employment history. They can gain structure and routine in their lives. It's a job opportunity. It builds self-esteem and confidence to work. It increases their ownership of services, the commitment to services. It improves people's personal worth. It reminds me of Sam Friedman's adage that involving PWUD in services is a form of redemption through social struggle. Meaning a lot of people that I talk to that are in the throes of addiction feel like they have nothing to live for, no goals, nothing to do, no future. Being able to be part of something, to be part of a community, part of an organization, having social relationships is the first step to really ameliorating that alienation, bringing people into the community. And this in turn generates motivation to manage use. Next slide, 28. I just want to point to some resources as I close up here. Some of which I've used for this presentation, but that are rich with practices and examples of how to incorporate drug users into your programs. This one is from the International HIV/AIDS Alliance. It's a fantastic resource. This is slide 28. Slide 29. This is a great resource on how to build collaborative interventions for HIV and HCV programs, involving people who inject drugs in helping deliver services. This also can be seen as peer navigation as well. Next slide. The Harm Reduction Coalition has a wonderful resource entitled Peer Delivered Syringe Exchange Toolkit. Has a lot of information on how to incorporate peers and people who use drugs into harm reduction. Go to 31, please. And lastly, I would like to close by saying that the evolution of harm reduction as a response to the AIDS epidemic should remind us that people who use drugs need to be central to the development of tactics and strategies for controlling the current opioid epidemic, like needle exchange, lane naloxone, safer injection, etc. Active drug users are in the best position to discover and develop novel practices to reduce the harms associated with the current fentanyl crisis, endemic polydrug use, and the sharp rise in injection-related infections. And I have a couple more slides, but let's end there and go to slide 33, which is the contact information slide, and my thanks to everyone listening and for the RX Summit for hosting this webinar. Thanks, everybody.
John, thank you very much. Very thought-provoking presentation. We have had a number of questions that have already come in from the audience. I just want to remind everyone in the audience that you can still use the Q&A area below the slides to submit a question, and we will try to get through as many of the questions as we can up to the top of the hour here. John, we had a question that came in regarding a syringe exchange program in Cincinnati, and the individual asked, Cincinnati's first syringe exchange was a privately funded program until it was taken over by the county health department this past January. Now that the program is government-run, it has gone from being a grassroots person-first program to a program that pushes treatment on participants, and the health department calls it harm reduction. Do you find this to be common once a government organization takes over?
That's a great question, and hello to all my friends in Cincinnati. I visited that area and some of the needle exchange programs there. What I was trying to explain in the presentation was this is a general trend that we do see, and that's why I wanted to highlight really the origins of the harm reduction movement and the kind of the spirit of its early days. People who use drugs were central to the development of the programs. In fact, it was key in order to have them involved to reach the population and to make sure people trusted everyone. And to do so, you needed to have certain policies and practices in order to make that conducive for people to participate. But once it is taken over by state health departments, it changes because state laws come into effect. You also have social workers and other people that might be in the drug treatment field but don't necessarily know how to work with people that are unwilling or unable to go into treatment. And that's the population that harm reduction works for. People that are unwilling or unable to change and go into recovery or go into treatment. Now, on the other hand, I just want to say briefly to get to some other questions, is that partly this is the goal of harm reduction, right? It is to have health departments reform themselves and embrace harm reduction as an ethos for how you deliver services, especially needle exchange. And so I think what we're going to need to do as a scientific community and as a harm reduction community is to get involved to make sure that when that transition happens, that the programs are maintaining the practices that we know that are both evidence-based and effective to deliver those interventions. Because what happens is it sometimes devolves and becomes ineffective. And so how do we do that? An advisory board is a way to do that. Drug user unions organizing is a way to do that. But definitely need to think of ways to do that because their involvement is key.
Excellent. Very interesting. John, a question regarding fentanyl test strips. This came from a coalition, and they say, our coalition has considered the utilization of fentanyl test strips, but we have heard directly from people who use drugs that this would be pointless because there is now the assumption that fentanyl is in everything. Some members of our coalition disagree with this and want to move forward with the initiative. How would you navigate this issue? There is the sense that by involving people who use drugs in this work that we always need to defer to their expertise. Do you agree?
I do not agree, and that's actually one of what I was saying is that those two extreme viewpoints, that just because people use drugs that we have to take what they say as automatically useful, right, and is automatically worthy. No, drug users are the same as any other group of people, like I was trying to say. Now, that said, we do want to hear what people are saying about why not to use them, because there's a large group of people that are saying to use them, and kind of where do we fall on the line? The argument to say don't use them because we're going to assume that fentanyl is in everything is problematic because fentanyl is not in everything. For example, in our study in North Carolina, only 60% of the test strips came back positive, right? But in Baltimore, a place with endemic fentanyl, it might be close to 80 or 90. But what we found in our study is that even if people believed it was there, the process of drug testing itself, people like doing it. It slowed down the injection episode. It made people take an interest for what's in their drugs. And I would argue that we can't stop with fentanyl test strips, that we need to enlarge it and allow people to be able to test their drugs. And that includes, mass spectrometers at needle exchanges, perhaps, at, drug treatment centers. Because we're in a state of emergency now, and I don't mean to be hyperbolic, but we have a poisoning epidemic. Our drug supply is poison. In fact, some of my colleagues are arguing that we need to have an adage like bring heroin back, because a lot of places don't even have any heroin, right? It's all fentanyl. So yes, we have a poisoning epidemic. Fentanyl test strips are not a panacea, but they are showing promise as an additional tool in the toolbox.
Excellent. I think a few of our participants today, John, want to know a little bit about, any standardization of processes that they might be able to engage in. So I'm going to piggyback a couple of questions onto each other. There was one question about whether there are any defined job descriptions and organizational policies so that organizations can use volunteers and hire employees who are active users. And then there was another question regarding credentialing, whether there are any credentialing guidelines or organizations that could be recommended in that area. I know some of this is very new, so I wondered if you could talk to both job descriptions and maybe credentialing issues.
Yeah, so, there are some programs that do have job descriptions, but again, more of a universal approach, meaning that I think that job descriptions, let's say for an outreach worker or someone to help deliver services, doesn't really need to be for persons who use drugs specifically. I actually think that a lot of the ones I've seen say, people who actively use drugs can and should apply. And by putting that in, I would argue we really need a universal code of conduct. And so I look at, let's say, someone who uses heroin similar to someone who uses marijuana, especially in a place where marijuana is not legal, meaning they do illegal things, but they don't do that at work. And if they do that at work, there are consequences for that. So I think that's what the path we want to go down. But at the same time, people who use drugs have additional challenges. So once they're hired, we really do need to think of ways to address those challenges and barriers. But in terms of a job description, I think we can go more universal and then say people that actively use drugs should and apply. And if that person contacts me, I can put them in contact with people that would have such job descriptions. Credentials are another thing, and we've been thinking about how do you credential the expertise that comes from lived experience. I think one of the best outreach workers on the planet is Mark Kinsley from the Texas Overdose Naloxone Initiative in Texas, and he calls himself a streetologist. And, it captures really the extent of having that knowledge, but that knowledge being difficult to sell in a job interview and stuff like that. So I think, we haven't wrapped our head with how to credential people with the lived experience of drug use, but I think this is something that the harm reduction community has started to do, and I think it would be a nice call to action to think about that.
And John, we're going to wrap up with one more question and with a thank you from a participant in Wisconsin for the work that you have done there. And then he asks, when do you think the U.S. will see its first above-ground safe injection facility?
Yeah, I'm really bad at ESP and speculation like that. I've never been good. But what I do believe is that if this poisoning epidemic continues, we will have it one way or another. If you just follow the history of needle exchange, and that's why I put that conceptual framework up there between law enforcement and public health, because law enforcement, as we saw by Rod Rosenstein, the Deputy Attorney General's response to safer injection, is giving similar arguments to needle exchange, right? It sends a bad message. It's morally wrong. We should be controlling. Same thing as needle exchange, where public health is saying, yeah, all that's true, but we have people dying, and it's nearly impossible to stay safe doing this. And so should we prioritize, life and death over the kind of moralism surrounding drugs? So I eventually think we are going to see them, and they're going to trickle probably in the spaces that had needle exchange first, but it's definitely going to be contentious, and it's definitely going to take a combination of science and activism to come together and really push for evidence-based programs like this. And so I think we will have it in the future, but I don't see it any in the near time.
Okay. Well, that's all the time for questions, and I want to give everyone now some final instructions regarding CE credit. Again, do not leave this page. Please continue to stay on the platform. The site will automatically redirect you to a survey. The survey must be completed in order to generate your CE certificate. And again, for those watching in a group, please download the group submission guide in the Resources tab to the right of the slides and follow the instructions provided. Please note that CE credit is not available for the archived webinar. It is only available for the live event today, September 6th. I want to thank John Zabel once again for an excellent presentation today. I also would like to thank our sponsor, RTI International, for making today's program possible. Finally, thank you to you and our audience for participating today. We hope you will join us in the future for another IABH webinar. This concludes today's presentation.